from the Professor Kim and the Lu and the organizing committee to give me the opportunity to talk about my topic today is pneumatic retinopexy. I'm from Taiwan. I think everybody knows the treatment of the retinal detachment included 3 important points. One is you need to identify all the breaks. Secondly, you need to release all the attractions. And third, you need to create adhesion around the breaks. Then you can get a successful reattachment surgery. And everybody here are familiar with scalp buckle, which can achieve 80 to 100% reattachment rate of retinal detachment surgery. Of course, recently everybody was focused on the vitrectomy to treat the retinal detachment. In my country, most of the young retinal surgeons even didn't know how to do the scalp buckle. But however, don't forget, we have another cheap and low-cost choice. It's a pneumatic retinopexy. So in this topic, we don't have a very good high-tech and also no excellent video. Sorry about that. Based on the history of the retinal detachment treatment history, actually, the scalp buckle was first introduced by Dr. Gornay about 1920s, and followed by the introduction of the vitrectomy by Dr. McKemmer in 1980s. And this technique of pneumatic retinopexy was introduced recently in 1985. So it's a modern technique for repair the retinal detachment. So I think everybody now is talking about, should we give up all the buckle and the pneumatic retinopexy? Because now we have a micro-incision vitrectomy, and everybody was familiar with this kind of technique. And basically we can get more pay from this surgery. But however, there's several disadvantages of the vitrectomy to repair the retinal detachment. It's a good technique. But however, everybody need to have a post-operative position, prone position. It's a very painful procedure, and most of the cases will get a cataract after the surgery, and some of them will get a glaucoma afterwards. And talking about the scalp buckle, there's also several complications we need to notice. That this buckle can distort the eyeball, and some of our cases when you do the subretinal fluid drainage can get a choroid detachment and hemorrhage, and also some of the buccal material can get explosion and infection after the surgery. So actually, the pneumatic retinopexy has some advantage. First, the patient can get a very rapid visual acuity recovery and less pain. And it is low cost and very few complications. And most importantly, it's a less cataract formation. And it is an office-based minimal invasive procedure. So according to the study of the evidence-based analysis, actually the single operation reattachment rate of the pneumatic is a little less than a scalp buckle. It's around 70 to 80%, and the buckle is 90%. However, after the second procedure, the overall reattachment rate is similar with a buckle procedure. So I think pneumatic retinopexy is still a useful skill for us to reattach the retina. So after the introduction, let's vote for the retinal surgical technique. So if you agree, just raise your hand. This is a young patient, 30 years old, and you can see some subretinal pain here. It's a chronic retinal detachment with inferior breaks. So what is your choice? So if you agree the pneumatic, raise your hand. Okay, no one. How about scalp buckle? Oh, good. Very good consensus. How about vitrectomy? Okay, there's some vitrectomy lover here. Okay. How about this one? Pneumatic. Okay, very good. We have more supporter of the pneumatic retinopexy. How about a buckle? Okay, some people can do buckle for this case with posterior hole and also has a macula hole. So how about this one? Anybody agree the pneumatic retinopexy? Good. Okay. Scale buckle. Okay, good. How about vitrectomy? Okay. So I think everybody know the point of the pneumatic retinopexy. I think the most important thing for pneumatic retinopexy is patient selection. So standard patient selection included the breaks occupy no more than 3 o'clock hour, and most of the retinal detachment located in the superior 8 o'clock hour. That's the standard selection. And the importantly, patient were able to maintain the proper head position. So the selection position is the most important thing for pneumatic retinopexy. So according to the distribution of the brake in the eye with a retinal detachment, theoretically 75% of the retinal detachment cases are feasible for pneumatic retinopexy according to the location. However, also we need to consider the situation of patient. So there is two basic surgical techniques involved in this pneumatic retinopexy. The first one is called one-step retinopexy. We do the cryopexy prior to gas injection. After the anesthesia, of course. And the second is involve two-step retinopexy, which I favor this technique because only use topical anesthesia, then we can finish the procedure. You inject the gas first, then you apply the laser when the retina is attached 24 to 48 hours afterwards. And also the very important thing is that you also laser on the lattice or other high-risk area to prevent attachment of the retina. So actually the surgical procedure is not very complicated. You need to identify all the breaks and the high risk area, and most of the time if you use a two-step cryopexy, you only use topical anesthesia and the sterilization. Maybe you can do some paracentesis before you inject the gas. Then you inject a filter gas. Maybe it's a C3FA or SF6, depending on the size of the eyeball, something like that. As much as possible. Then you check the artery. Then you finish the job. I think the most important thing is the post-gas injection. You need to emphasize on the positioning of the patient. So most of the time you can make a mark on the eyebrow of the patient and the maintenance of the position for at least 16 hours a day and for at least 5 days. And it depends on the situation of the patient. And I think the most important thing is that you need to close follow up the patient. If it is failed, you can perform a second procedure. You can do the pneumatic retinopexy again, or you do the buccal or vitrectomy according to the condition of the patient. Of course, there's some complication of this procedure. Like I think the most sometimes we can see the new and the missed breaks. I think it's very important to find the new breaks. So we need to close follow this patient. Of course, we can get a fish egg or subconjunctival gas or gas entrapped in the prehyaloidal space, which cannot reattach to the retina. Or sometimes I don't have experience of endophthalmitis, but there's a report that even the pneumatic can get the endophthalmitis. And also we need to close follow up the PVR change after we do the pneumatic retinopexy. So there's some also suggest to avoid the fish egg bubble. According to the most important is that the tip of the needle, you don't inject the needle very deep into the vitreous. Then you inject very slowly. This technique will reduce the risk of fish egg. And some investigators suggest that if you find the fish egg, you can try collecting them into a single bubble by striking the eyeball with a finger or cotton tip. But according to my experience, most of the fish egg will become a big bubble 20 hours or 48 hours later. So maybe this is too aggressive to strike the global. So according to this survey paper, that past 20 years, almost 4,000 eyes has been done by the pneumatic retinopexy to reattach the retinal detachment, and the single operative success rate is 74.4%. So it's like what we introduced, that most of the break, about the 75% of the break, actually you can use a pneumatic retinopexy to reattach the retina. And the final operation success rate is 96.1%. It's quite high. And I think the most important thing to emphasize that the new break has been found in 11%, and also the PVR is 5%. So this is what we need to close follow up the patient. So of course, the pneumatic retinopexy is not a perfect procedure. There's some contraindication that, like, breaks within the inferior 4 o'clock hour PVR change, or the patient is unable to comply with the positioning, or there's extensive visual retinal traction, or there's a head media. You cannot do a very complete observation of the retinal condition, just like the patient if has uveitis or vitreous hemorrhage. I think is a kind of contraindication. So it is inferior break is an absolute contraindication for pneumatic retinopexy. So if the patient has like break in the 6 o'clock, then he needed to sleep like a bad man. Is that right? Actually, there's a study from Taiwan, and they try to modify the positioning of the patient with inferior break, and they also get about 75% of the success to reattach the retina with pneumatic retinopexy. So this is my final slides, and I think even we have a microincision. Richard told me we have buckle. Don't forget, if you have a vacation, you want to have a vacation, and before the vacation, some resident call from the emergency room say there's a retinal detachment, and actually you can go for the vacation. Just take 20 minutes to do a pneumatic retinopexy for the patient. So don't forget. Pneumatic retinopexy is still a useful technique for selective retinal detachment cases, and I think the key point of this technique is that we need to do a case selection. is very important, and you need to identify all the breaks and also the risk area. And if you see the risk area like galatis or some area you are not very comfortable, then you just laser them. And also you need to emphasize on the patient that the position is very important, and we need to close file this case. And if this procedure fail, do the second procedure as soon as possible. So thank you for your attention.